This presentation will focus on elbow injuries in the athlete by Laith Chazraoui. Typically for board preparation on the test, they like to focus on the different phases of throwing if a question is going to be asked on it, particularly at what phases of throwing is the athlete at the greatest risk for injury. And it's typically the late cocking, acceleration, and deceleration phases. We'll focus on elbow injuries in this talk. In terms of the elbow anatomy and throwing biomechanics, the key is on the elbow valgus torque, particularly highest in the cocking phase through the deceleration phase. You get a tensile stress along the medial side of the elbow where both the ulnar collateral ligament, the flexor pronator mass, and the medial epicondyle apophysis are put under a lot of tension. You get shear stress on the posterior compartment, and this typically causes osteophytes to form on the posterior medial tip of the olecranon and trochlear and olecranon fossa. You get compression on the lateral aspect of the elbow, and this stress at the radiocapitellar joint could be as high as 500 newtons. And then you get that about 64 newton meters of valgus torque on the medial aspect of the elbow. So when you look at also, what's absorbing all that force? In addition to the ulnar collateral ligament, you have these dynamic stabilizers on the inside of the elbow, particularly the FCU. This comes up sometimes. What's the main dynamic stabilizer? It's the flexor carpi ulnaris. Second is the flexor digitorum superficialis. Again, those posterior shear forces, they like to talk about it in relation to valgus extension overload, where you get the shear medial tension on the elbow, and then this valgus extension overload where you get these osteophytes on the posterior medial aspect of the elbow. Other things to understand about the anatomy, particularly when you're looking at the UCL, the anterior oblique ligament is the strongest, and that's typically what we're reconstructing when we do a UCL reconstruction. It's made of the anterior and posterior bands. There's a posterior oblique ligament, or the posterior bundle, which we don't reconstruct. So don't get confused when they talk about the anterior bundle. There's particularly two bands, the anterior and posterior band, that we're reconstructing with the Tommy John procedure. There's a posterior bundle that's interwoven in the capsule as well as the transverse bundle. But it's really any answer is going to really focus on the anterior oblique ligament. So when we get back to what the tensile strength is, it's only 33 newton meters of the native ACL. What I just said before is that the elbow experiences with throwing 64 newton meters. So how is it possible? Well, this question comes up a lot where they talk about the only way that the ulnar collateral ligament doesn't tear each time is that there's a dynamic contributor, and that's the FCU, that's the primary one, and the FDS is secondary. The thing to understand also is when you get MRIs on these patients' elbows, particularly pitchers, and the ones that are uninjured, they all have changes that are going on. So despite the fact that they have no symptoms, they still have findings. And some of them have findings that almost look like an ulnar collateral ligament pathology or tear where they have thickening of the ligament itself. So just be aware of this. When you see the history of the patient that they present on the test, you're going to get a patient that has a history of pain in the late cocking or early acceleration phase of throwing. Sometimes they hear a pop, other times they don't. And they complain of decreased velocity. They can't throw as far, their accuracy is off, or some combination of all of them. When you look at pitch type, sometimes this comes up on the test. You're really looking at what causes the highest torque on the elbow. That's the curveball for sure. The fastball and slider do generate the greatest force on the shoulder and elbow, but they like to focus on pitch count. And the kids or the athletes that have the most injury typically have the highest pitch counts that are there. So really a lot of the prevention is focused on limiting pitch count. When you examine them, you're looking for valgus laxity. Oftentimes it's difficult to pick this up. But what you're really looking, for is in your physical exams to see if you could assess this. And typically we do a valgus stress with the elbow in 30 degrees of flexion. This could be, certainly a static maneuver where you're stressing them at 30 degrees. As is seen in the lower picture, then that's a little more like 90 degrees. But you're seeing if it reproduces pain in the medial aspect of the elbow. There's a modified milking maneuver where you're moving the elbow as you're sort of grabbing the thumb in the milking position. But the one that's most commonly used and the most sensitive and specific is that the upper picture, which is the moving valgus stress test. Sometimes it's called the O'Driscoll test, where pain is highest between 70 and 100 degrees of elbow flexion. Getting back to what can cause valgus laxity, don't forget, if you get a kid, you could have a medial epicondyle avulsion, look for a UCL sprain, and in the exam, always assess the ulnar nerve and look to see if they have pain over the flexor mass. Again, as part of the history and physical, you're doing this valgus extension overload test where you're pronating their arm and you're forcing their elbow into hyperextension with a little bit of valgus stress. And you're trying to replicate what's happening in the deceleration phase, where they're overloading that posterior medial compartment, and you're really assessing for tenderness and crepitus over the posterior medial olecranon. Laterally, you're assessing the radial head, capitellum, you're looking for crepitus, and things on the lateral aspect of the elbow that can cause pain are OCD lesions and synovial plica. When you're looking at imaging, x-rays, AP lateral and obliques we typically get, joint space narrowing, osteophytes, loose bodies, the typical stuff you're looking for. In a kid, you're looking for apophysitis to see if that medial epicondyle is in the wrong position. In terms of valgus stress films, they've asked these questions less and less over the years. You're really looking at medial joint line opening. Anything greater than 3 millimeters may be diagnostic of a UCL injury, though patients who are uninjured and are throwers can sometimes have laxity along the medial aspect of their elbow. But really, the key thing to get if you're suspicious for a UCL injury and also suspicious for either a plica laterally or an OCD lesion is an MRI. And then an MR Arthrogram adds a little more increased sensitivity in terms of picking up small tears of the UCL. In terms of addressing these non-surgically for throwers, it's typically only 42% successful. I doubt that they'll ask you questions about PRP injections. We typically rest them, but most of these patients, if they're high-level throwers and they have an MRI-confirmed UCL pathology or tear, they're undergoing some sort of surgical management. And typically the initial Jobe reconstruction, and this is just more to get a global understanding of this, was where they literally took off the entire flexor mass, the submuscular transposition of the nerve, a lot of morbidity, great visualization in terms of drilling your tunnels. But the interesting thing is when Tommy John had it, he ended up with an ulnar nerve palsy for several months after the procedure. The modified Jobe, which was sort of the second phase of this, is where you elevate the flexor mass. You're still plus or minus moving the nerve. That's typically considered the gold standard of returning athletes to competition. There are other ways to do this. The docking technique also has equivalent outcomes with return to sport and getting patients back to high level of play. And in this case, you're splitting the muscle. So you're basically splitting the FCU and you don't typically move the nerve, and the outcomes are the same. I doubt that you'll get a question about interference screw fixation, but at least the biomechanical studies have suggested that using an interference screw on both the humerus and the ulna, again, allows smaller incisions, less dissection, may achieve similar strength compared to your typical drill tunnels that you do with either a docking technique or a modified Jobe. Getting back to valgus extension overload, these athletes, you really got to look at their posterior elbow, see if osteophytes are limited their extension, and also see if loose bodies are locking or catching. Typically, posterior elbow pain and valgus extension overload, you're looking at activity modification, cortisone injection, sometimes NSAIDs, rests, and then a gradual return to throwing. In terms of surgical management, the trick that they'll probably go for on this is that it's very rare now that you would do just an isolated posterior medial debridement. They want you to think that there's some sort of UCL insufficiency, as a majority of these patients do have some sort of UCL insufficiency present. Again, aggressive resection of the posterior medial olecranon you want to try to avoid, as this increases the stress on the UCL. Several studies that have confirmed this. Posterior olecranon debridement in pro pitchers, 25% of them then required a UCL reconstruction after that. This is supported by biomechanical cadaveric studies, which show that increasing posterior medial olecranon resection increased the UCL stress. Another study demonstrated UCL insufficiency can lead to VEO and posterior medial olecranon osteophytes. So what came first, the chicken or the egg, is difficult to often figure out. But in this case, they're not going to ask you that. They want you to understand the relationship of VEO, ulnar collateral ligament insufficiency. Olecranon stress fractures, we see these typically in adolescent athletes. The acceleration phase, there's strong triceps contraction on the olecranon, a lot of shear and distraction forces on these open apophyses. Typically rest helps them. If they don't get better with a non-operative treatment, that's when we start thinking of screw fixations. In physical exam, they typically have pain with the resisted extension, where you're contracting the triceps. And again, we try conservative treatment. If this fails, you do a single cannulated screw down the intramedullary canal. Getting to other causes of elbow pain in the athlete, lateral elbow pain, OCD lesions. These patients typically have some sort of elbow contracture. They complain of locking, especially if there's loose bodies associated with it. You're really looking at the classification system. You see these in younger athletes. The younger they are, the more likely you are to treat them non-operatively unless they have a loose piece or a detached lesion. Again, if they fail a conservative treatment protocol, especially if the cartilage is intact, you're looking at some sort of retrograde drilling or antegrade drilling as well, depending on the size of the lesion. But for the most part, you're taking them to surgery even if they're really young, if the piece is loose, unstable, it's catching, locking, and they can't get their motion. And these patients, typically you're doing microfracture after you debride the lesion. Don't forget about Panner's lesion. It could be a trick. These tend to be younger athletes, 8, 9 years old. It's not OCD lesion. If you look on the x-ray, it looks like a growth plate that's there. So don't be fooled by that. And typically the difference they'll give you both the age being much younger than the typical 12, 13, 14-year-old boy pitcher that this happens to. Radiocapitellar plica, oftentimes it's pronation and elbow flexion with palpation of the radiocapitellar joint that triggers the pain. They have clicking, and initially a conservative treatment protocol is indicated for this. An arthroscopic resection of the plica after the conservative treatment can sometimes be an injection as well. But anytime there's lateral elbow pain, think also radiocapitellar plica. Thank you, guys.